All right. It's 7 o'clock, so I think we'll go ahead and get started. So hello, everybody, and thank you for joining us tonight for our panel about disabilities and health disparities. We're going to start in just a moment, but first I'd like to fill you in on some background information. Wfyi and Side Effects Public Media received a grant to participate in a national project called Move to Include, which focuses on the stories of people with disabilities. The project is led by WXXI in New York and is funded by the Corporation for Public Broadcasting. As part of the project, we've been writing pieces and designing content around disabilities-related issues, one of which is disproportionate health outcomes when it comes to medical care. That's why we've created this particular discussion. You can learn more about the other stories and pieces we've been working on by visiting wfyi.org/move-to-include. I'd also like to say a huge thank you to the folks at Special Olympics Indiana who have been absolutely instrumental in the formation of this panel. So to the topic at hand. This month marks 30 years since President Bush signed the Americans with Disabilities Act into law, and while the US has come far since then, we still have a long way to go when it comes to achieving health equity. So to talk a bit about that, we have Dr. Mary Ciccarelli, Professor of Clinical Medicine and Clinical Pediatrics at the Indiana University School of Medicine. Thanks for joining us, Mary.
Thanks so much for having me.
We also have Anastasia, also known as Nastia Helmick. Nastia is an athlete leader with Special Olympics and leads one of the group's unified fitness clubs. So good to have you, Nastia.
Thank you for inviting me.
We are also joined by Kevin Caligan, Special Olympics athlete representative from Cass County. Hi, Kevin.
Hi, my name is Kevin Caligan. I'm from Cass County.
Thanks for being here.
You're very welcome.
And so with that, I think we're just going to go ahead and jump right in. Let's start with sort of the language of the Americans with Disabilities Act. The ADA requires that healthcare entities provide full and equal access for people with disabilities. That means required to make reasonable modifications or changes to policies, practices, and procedures, must ensure that communication with patients with various disabilities is as effective as communication with other patients, and that healthcare facilities must ensure those facilities are accessible to people with disabilities. Like physically, it has to accommodate the equipment people might need to get around. Mary, how well are we doing in terms of those goals as a country?
I think we've come forward in 30 years. I think we have plenty of room to grow still. I think that for each of those topics, we now meet the letter of the law in most facilities, but there's some depth to that letter of the law in terms of really making the right modifications, communication, and accessibility to all different types of disabilities and people who need individually different accommodations.
Yeah. When we talk about disabilities, the term encompasses such a huge array of conditions. Before we go any further, could we break that down a little bit and talk a bit about what that means?
When I think about disabilities, I think about individuals who have limits in their ability to participate. And those might be driven by a problem with the body's ability from a motor perspective, movement. It might be motored by a sensory problem like vision or hearing issues. It might be a cognitive or emotional limit. Both people with intellectual or developmental disabilities, as well as people with serious mental illness. And so there are each of those different types of disabilities when we talk broadly about healthcare disparities across all of disability.
Great. And when we talk about like a health disparity, it's different for folks kind of depending on the disability. Broadly though, could you describe some of the kinds of disparities we see in health outcomes?
Well, we look at things like mortality and morbidity, and we look at access and use of care. And there are actually disparities across all of those for persons with disabilities. And so being able to access care for whatever barrier gets in your way, whether it's your own ability to do that accessing of the care or your transportation, or when you get there, your ability to interact with it. And then there is we know that people with disabilities have a higher rate of problems with heart disease and diabetes and hypertension, which are maybe the three top chronic diseases we think about in adult life, but also have problems with comorbidities that are more specific to their disability. And that might be having problems with seizures if you're a person who has intellectual disabilities, or having problems with your skin integrity if you're a person who has to use a wheelchair and you get pressure sores from sitting in a wheelchair. So there are different kinds of increased morbidities and disparities in this group. Age of death is earlier in people with disabilities in general. Frequency for the whole group of Americans who have disabilities, increased rates of smoking and obesity and other serious comorbidities occur.
When we talk about access, I know in other reports that we've done on disparities in a bunch of different populations, we talk about how access often affects an individual's ability to, I guess, stay on top of routine maintenance, your yearly physical, the things that I kind of take for granted, like my yearly dentist appointment. How does that access delay care for someone with a disability, and what does that do farther down the line?
I'll talk about it generally, and then maybe we'll ask our other guests to tell us about some of the experiences they've seen or heard about as well. I think that access can be something like what if going to the dentist for you is scary and you just can't go because you're afraid of the dentist? What if when you're at the dentist, you can't hold your mouth open comfortably for the period of time that you're asked to, and you need a different way to have supports to help maintain the positioning? Those are all types of things people need adjustments for when accessing something like dental care. In fact, certain insurance plans like Medicaid as compared to other plans maybe have different features in terms of the dental services they even provide through their insurance. So there are disparities that might be built into the system in terms of the type of insurance a person has, or built into them personally, or built into the way the environment of the health center receives them.
Naskia and Kevin, have you had any experience like that where, there's just been a barrier to getting maybe your yearly doctor's appointment or something like that, or do you know of someone who has?
In the past, I have. When I became age of 26, I was kicked off my parents' insurance. So I had to find the access list of, okay, who do I go to a doctor, because my insurance is different than my parents. And a lot of places don't take my insurance. So I had to ask people around, and they're like, well, this place takes this. You can call them and see if they would be able to. It's challenging because a lot of people don't take certain kind of insurance and certain kind of plan. So I literally had to figure out a way to get my dentist to figure out who I needed to go to. And I called my original dentist and I said, I can't find anybody. I've tried to reach out. I haven't been able to find anybody. And he said, well, call this place and I know they accept your insurance. They would be glad. And I did, and I set up an appointment. But it was kind of challenging to go through that to find, because there's not a list of dentist places or a list of where you can go to a doctor or for anything. It's kind of hard to have an eye doctor. It's just harder. There needs to be some sort of a list for people.
Thank you. Kevin, do you want to add anything?
Over my adult years, I've had different variety of jobs. There's different health insurances over the years, different stuff, changes happens every day. I used to go to my eye doctor for years since I was a kid, and I went to stay with this person. Then I had to go to someone else because I didn't have had different health insurance. I was not under full-time employee anymore, I'm under Indiana HIP plan now. That's universal health care for Indiana people, I think, if I understand it right.
Mm-hmm.
And I like both eye doctors the same. No complaints, great people, small town America. Then recently this year, I've had my dentist since middle school, so I have to switch my dentist recently because I've never met this person, but changes happens every day in healthcare, if I understand it right. It doesn't matter if the bedside manners could be good, or it doesn't matter what. I don't explain it. My grandpa was a retired dentist, so not from here, but I've been lucky to have good health care for eye care, tooth care, heart care. That's what makes America great.
When you had to switch providers, switch your eye doctor, switch your dentist, how did you find someone new to go to?
A couple years ago, I switched my eye doctor. I love this guy too. Cool dude. Small town America. Just my parents helped me out and stuff, and I know people in my hometown. It's a small town, so I know multiple people. I know multiple. It's a small town, and my mom helped me out recently for my dentist. She called around for me. I was kind of a little nervous about my dentist because I was so used to that gentleman over the years since middle school, and I'm 35, and I know good dentists when I see one in my family blood. So I'm going to see if this new guy's good for me or not, but that's part of life, They don't accept certain insurance and some do, I wish we could negotiate healthcare, but money's a heavy subject, I guess, with the doctors and people in Washington, D.C., if I understand it right. Sorry I said that, but.
Mary, I'm going to jump back to you. Describing some of the disparities that we discussed a little earlier, why are we still seeing these 30 years after the passing of the ADA?
I think there are multiple layers of improvements that we need. I think that persons with disabilities need the appropriate education about their own health, delivered in a manner that they can understand and use. They need information on specific conditions that they have and specific vulnerabilities they have. And we're not always good at delivering that information in a manner that's that is received so it can be used. Similarly, and so thinking about smoking cessation programs out in the community or diabetes education classes out in the community, they're not always adjusted to fit the needs of someone who might have a lower reading level of literacy or who speaks or thinks at a slower rate and therefore things changed in their speed. The next layer is that anyone who provides caregiving or social support for a person with disabilities also needs to know what is their role, where should they step in or not step in terms of supporting that person. And if you're a person with disability who can't feel your own body sensorily in a normal way, maybe you need somebody else to help you when you're having a problem because you don't notice it yourself. If you, for example, in a wheelchair and can't feel your body from the waist down, you have to look at your heels with a mirror to make sure the skin is okay there because you can't feel it. And so maybe caregiver supports are more important in all of those kinds of ways to people who need those adjustments just in their own circle of support. So those folks, whether they're natural supports in a person's family or people who are paid to do that work, they have to be educated. And then the next level of need is education of health professionals on how to think about how do we talk at the right health literacy of the patients we're serving, and how do we avoid using terms that are so medical that they shoot over anyone's head, and then how do we think about adjustments and involve the person themselves and not talk around them to their caregivers. Those are all skills that health professionals need to learn. And I think we have that's different from saying, do you have a mammogram machine that works for a person in a wheelchair? That's concrete. But the other things I'm talking about are harder to penetrate across the whole population. Those types of education programs of the person themselves, so the support system and the health professionals.
We got an audience question that sort of touches on something we might have spoken about a little bit earlier, but they wanted a little more detail. They were wondering, do these disparities differ based on the type of disability, such as someone who maybe has a visual impairment versus an IDD?
That's a hard question to answer because we analyze data collectively across persons with disabilities at a national level. And there's been some work on separating it by motor sensory. And so interestingly, for different things like heart disease or lung disease, there's slight variances in the different, across the different types of disabilities. Interestingly, for example, people with intellectual disability don't tend to have as much respiratory disease as other people with other disabilities because in general, people with intellectual disabilities don't smoke as much as people with other types of disabilities. And so there are certain subclasses, but most of our analysis as a health system nationally looks at the whole group.
How does that complicate being able to move forward when you don't have data disaggregated by more specific metrics?
So the countries that do data analysis at a population level better than us, and there are a number of those countries, in a very crude and general way, it's countries that have national health service programs. They do a better job of both analyzing the data and building programs around the data. And so we need that. We need a better system of population health to help us with that. Better research, better real-time information that helps us adapt and change.
This audience question is slightly related. They were wondering, one of our viewers is wondering if there is data to show that states that have expanded Medicaid have better quality of life for their residents with disabilities. Do we know that?
I've not read any. We know that access to healthcare with healthcare financing plans improves care in general. I have not seen anyone analyze that for persons with disabilities because if you remember, the expansion really wasn't targeted specifically for people with disabilities. If you have a disability, you're likely eligible for already a program in your state before we expanded. And so the people mostly who came into the expanded programs were people who were low income employed individuals without disability. And so I'm not sure that it made a difference specifically in disabilities and the care thereof.
Gotcha.
Analyzed, so I'm guessing.
Really quick, I'm about to pop over to Naskia and Kevin for a bit, but before I do that, Mary, I was wondering if we could take just a quick pause and let the audience know what you do as a physician and a researcher.
So I work at the School of Medicine and at Eskenazi Health, and I have a program that I help run called the Center for Youth and Adults with Conditions of Childhood. It's funded through the State Department of Health Wfyi program, and we help serve in a comprehensive approach to the transition from pediatric to adult life. And primarily the population we serve are people who have complex and multiple disabilities. Those folks tend to have the most difficulty in making that move from pediatric care to adult care.
Thank you. Now I'm going to switch gears. Kevin,
Yes.
You're an athlete representative for the Special Olympics in Cass County, and you're also a health advocate. I was wondering if you could talk a bit about what each of those roles does and why you got involved.
A health advocate goes beyond Special Olympics. They're role models for the athletes and recruit volunteers all over the state of Indiana and stuff, or around the world. We travel to different places. We go to different meetings, and we further our education about health outside Special Olympics, and we do all kinds of cool stuff. We meet new friends from different chapters of Special Olympics, different states, I've met friends from different countries even. Like, I guess Canada counts, because I've had a meeting with them before. It's pretty cool.
Yeah. You ran in Greece for one of your events, didn't you?
I ran Greece in 2011. I won a bronze in a 5K run. I was this close to silver, like less than an inch at the finish line. It was the closest finish I've ever seen. It was phenomenal. 90-degree heat. I'm not much of a heat runner in my running prime, but that was cool to run the Olympic track. It was cool.
Yeah.
Cool experience. Surf track. Yes.
Sorry, Kevin, I'm just keep interrupting you.
No, I'm interrupting you.
Your journey to become a runner kind of started when you were about 10. You have a pretty interesting medical story. I was wondering if you would mind sharing that.
Yes. I used to be a toe walker.
Could you say a little bit more about what that means?
Yes, I'll be more than happy to. I'm open about it because I have you and my Special Olympics friends on here and the doctor on here. I was a guinea pig at 10 years old. In the 1990s, like around 1995, I was born in 84. I'll tell my age. Botox wasn't famous around the mid-90s, I've heard. I used to go to Dr. Dietrich's office at Methodist Hospital. They have a bunch of medical offices there, and they stuck 8 Botox shots in my legs to loosen my muscles as a toe walker. I used to walk my toes, couldn't help it. It was a success. It was some of my leg muscles, and I had walking casts around later on and stuff. It was interesting. It was hard for me to go to like skating parties. I've sat the nosebleed section at Market Square Arena for Indiana Pacers, but I turned down the handicap section to see Reggie Miller, but that's all right. But life goes on, and I became a good athlete after that. In 6th grade, I joined a cross-country team. In high school, I ran varsity and stuff.
And that's because the Botox injections allowed your muscles to relax so you could lower your heels.
And I remember as a boy, I used to go to like Disney World every year, and I remember I used to be in pain. I used to thought that was a normal pain. As a kid, going to Disney World was like going skydiving or something, of that pain. And I remember I used to go to Disney World in Florida, but one year I went to Disneyland in 6th grade. One year before my growth spurt in 7th grade, and I was so much pain. Like, I used to see these people get these free passes and stuff to cut in line, but I was about to leave, and the Disneyland employee was about to give me one because I was so much pain. They thought I was in trouble, just laying on the side, stretching my legs. My parents was, and it's amazing how strong the human body is.
Yeah, well, kind of going with that, you mentioned that after you stopped running so much, it got kind of hard to maintain your health because you weren't like doing that like strenuous workout anymore. Could you tell us a bit about what you did once it got kind of harder to do that? How did you fix it?
Lately, I been walking the trails right near me because it's been a tough year. 2020's, I'm sorry, a lot to say that, but I haven't been to gyms or exercise clubs for months now, so it's hard for me to keep in shape and stuff. I want to keep in shape and stuff.
But it's kind of hard when you don't want to go to the Y because there are so many people around during a pandemic.
Yeah, that's what I was thinking too. And in a couple months, it'd be nice when renovations done with the YMCA. We got awesome YMCA. They're doing awesome renovation stuff. So I just don't like, not to be a chick, and I just don't like crowds so much lately. Not to, I don't know, not to judge.
No, I get that feeling. I don't really like being in crowds right now myself.
Yeah.
Nastya, I'm going to pop over to you for a minute. You have your own journey to talk about, and you're a leader of a unified fitness club. I was wondering if you could tell me a bit about that, what your role is like, and why you decided to do it.
So with my role being with Special Olympics, I didn't start doing any kind of sports till like 6th grade when I was first tested. My parents and I really didn't think about stuff. My parents helped me join and they supported me. And then over the years, I was involved through volleyball. And half of my friends who are through there, which I love my friends, I've noticed them that my parents showed me eating healthy stuff, and I turn around and in my mind, I was like, oh, okay, so I could eat this. And then I realized towards the end, when I joined ALPS, is when they introduced the unified fitness clubs. Is when I joined that. I was like, oh my gosh, I need to eat healthier. My friends need to eat healthier and do a lot of the exercises and a lot of things to do for them to help them. And especially half of my friends take so much medication that those medications aren't really good for the athletes due to the fact it's gaining weight, and it's how can we control that. So when I first started, my dad and I started, and I thought it was great. It was a great opportunity to get friends, and we had like 30 people first started, and we still continue. We may not meet together. We do Zoom meetings, and we try to stay active with each other and try to figure out a way to keep it still going when we are not even meeting face to face during this pandemic.
Right. Before I ask you a bit more about the fitness club, really quick, could you tell folks what the ALPS program is?
ALPS is Athlete Leadership Program. It's to help athletes to be able to speak about or be able to present or be able to stand up for other athletes who are not that can't speak or they can't do things, but that you have athletes who are more able to do that. So it's just finding the comfort.
Right. Now, with your club, before the pandemic hit, what kind of activities was your club doing to stay fit?
So before the pandemic hit, we would meet regularly, and once a week we would do walk together. Sometimes we do exercises together. One of my favorite things I like to do with them, it's called Sally Up, Sally Down. It's a challenge where you basically squat several times, and there's squats where you hold in position. So it is stretching their legs. So we do have athletes who can't do it, so I have to modify it to it. So a lot of the things, that's what we did, but now since the pandemic hit, it's kind of harder.
How do you, how have you changed what you do? What kind of activities do you do over Zoom now?
So the biggest thing that we do over Zoom is we talk about drinking water. We talk about washing hands. We talk about when you go out to a restaurant or you go out to public, you need to wear a mask. Make sure you have hand sanitizer. So we do a lot of the things that some athletes don't understand when on the news, they're like, oh, you need to do this and this. Well, some of them don't get it. They want to be social with their friends. They want to be able to do like everybody else. So I talk about all the health risks that they're going to take when they go into public. And so we talk about all the things, the safety precaution that they need to take. And then sometimes we go out and walk. So we have our walking Zoom. So I'll have my phone and I'll be outside walking, and I'm hoping the athletes are going to be doing the same thing. So, and sometimes I'll put my phone down and we'll do squats. Sometimes we'll do jumping jacks. It just depends on what I have planned for the day.
It's really cool that you've been able to build some COVID education into your program. I have a question that is for both of you. If you want to take turns, kind of taking a crack at it. We talked a little earlier about the challenges folks with IDs face when they go to the doctor, and some of your own experiences. I was wondering, what would you like doctors to do and understand when a person with an intellectual disability is their patient?
I've noticed as a full-grown adult, doctors' personality is always great. You know, sometimes doctors will come reach your hand before you reach theirs for shaking a handshake. You know, a firm handshake judges their personality, or be like Patch Adams, laughter is the best medicine. And there's some doctors come in different personalities, that's for sure. They have all kinds of imaginations how the human body works. Understand what it's like being a doctor, you know. They're just like the mechanics on the human body, I guess.
The biggest thing that I would say for doctors that need to understand is some athletes, for an example, I go to the doctor, and before the pandemic hit, my mom went with me all the time. And there are questions that I did not understand they were asking me, because I'm a slow processor, so it takes me a while to understand. So instead of they're facing me and talking to me, they turned right away to my mom. So, because my mom knows better about my health and knows a lot of things. And I just felt like I was a sitting duck in the room. I felt like they weren't really wanting to know my questions. They were just wanting to the answer. They were just rushing through it so they can move on to the next patient. So my biggest thing, I think the doctors need to understand, there are people with intellectual disability that their minds is slower. They take things slow to understand the question. And slowing down, I think, is the biggest the doctors need to focus is on being able to slow down and ask. And if the athlete can't ask, that's when you have the help. Since the whole pandemic hit, I've been going to the doctors by myself. And I still don't know how to answer some questions, but I try, because I tell them I don't understand what you're asking me. But in the way is the doctor should be able to translate it in a different way and help the other athletes, just like me, if they go to the doctor's office, or if they're out shopping and if they don't understand the specific reading task or something, is for somebody there to able to help. An example for doctors, slowing down and talk to the athlete instead of talking to the caregiver. If the athlete needs help, I think the athlete would ask.
Thank you. Dr. Ciccarelli, you mentioned a term for what Nastia was just describing a little earlier. Can you remind me what that term was?
We were talking about processing speed.
Mm-hmm.
Was that what you mean? Or
was it adaptive education? I'm sorry that I'm asking you to read my brain.
I think what I talked about was just accommodations in communication, right? And so thinking about how to use the other term I used wasn't specific to this, but some patients use augmentative communication devices, and knowing how to interface with a person's talking box so that you participate in the conversation and afford them the ability to use their voice, which might be with pictures or might be through an automated device. So there are two different aspects of this: how we give information as health professionals and how we receive back from the person their responses. And I agree entirely with what Anastasia said. There are times when if the person's having trouble answering the question, the person themselves, I think it's our job as the health professional to ask their permission. Can we ask your mom to give us some additional info if she has something to add? And that way it still regards the person as the primary person I'm working with, right? And I think that's what you are hoping to have happen, Anastasia. And I like the way you described it.
I'm going to keep going with you, Dr. Ciccarelli, if you don't mind. Could you talk a little bit about some of the work you've done in training physicians or looking at some of that medical training side of things for doctors?
There's a number of things happening around the country, internationally as well. I think the Special Olympics International and Special Olympics Indiana as a subgroup of that have done some great work on healthy communities, which works on training health professionals at Special Olympic events. We do health fairs, and we bring in dental students and medical students and nursing and physical therapy students to have experiences working with the Special Olympic athletes. There are also the programs that Anastasia talked about, the athlete leadership programs, to help, and there's a health track within that, where training of the persons are happening. So those are two different components that Special Olympics are doing, and that I think are really, really remarkable. There are the School of Medicine here in Indiana is working on a disability thread curriculum, which means they're working on teaching disability throughout the 4-year medical school curriculum. And we're launching that in the new curriculum that started now 2.5 years ago. And so it's still evolving, but it's bringing some of these exact conversations into the classroom and into the clinical settings for the learners. In addition, we have a large interprofessional education program here in Indiana that teaches health professionals across 9 different campuses in 20 different disciplines. And we're doing some of the disability thread curriculum within that as well.
Could you go into a little more detail about what that disability thread curriculum entails? If you can, I know it must be a really well,
I'll try to be brief, but get to the point. We've done some work with Special Olympics athletes as actually simulated patients in training health professionals, and actually being the patient themselves, rather than having an actor play a person with disabilities, which is not ideal. Having a person with disabilities play themselves and help teach communication to health professionals. We've used, in circumstances now with COVID, we're limited again, even in our education, and we've had to switch some of the curriculum into a more virtual, and we've done some videotaping of communications as examples. And we actually use some television shows or documentaries to show and make points as well. So those are the things this year we've had to use in lieu of some of the face-to-face activities that we have on the docket for as soon as we're allowed to do that again.
We had a question come in a moment ago wondering about the devices, the communication devices you were mentioning a little earlier. I think I was wondering if you could describe what those devices are. I've spoken to sources who've used them, but I cannot remember the name for them.
Well, we use the word augmentative communication device, or AugCom is the shorthand name for them. And there are a couple of different, there are vision activated ones, there are touch activated ones, and where people might touch with their finger 3 things on a board and then push the button and have that sentence be said for them. So I am hungry. I want to eat a hamburger. I hurt in my knee. And making a sentence like that, not by speaking with voice, but by speaking with indicating it on a box and then having the box speak for them.
Is that something that a patient normally comes to the office with, or that the office is supposed to provide for them?
They're very uniquely tailored to the individual, so the person has to bring those with them, but you have to be aware as a health professional that the person might be bringing a device like that and invite them to use it. Often, those families don't use it because they don't feel welcomed to use it, and so that's a way that we need to learn to accommodate better, because the person should have a voice in the encounter.
Thank you. We have another audience question for Nastia and Kevin. This person is wondering if the two of you have seen any concerns among your friends and fellow athletes about the coronavirus pandemic, and they were wondering what those concerns were that people have been talking about.
One of the biggest, I have some friends. I have a friend who has intellectual disability, and she works in a hospital. And she's around that all the time. And there was at one point where she had to be quarantined for 14 days because she can't drive up to the hospital. She has a person who drives her. And her driver was tested positive for it. So she was afraid because she lives with her parents, and her parents are older. Mm-hmm. And so she was like, well, I really don't feel comfortable doing anything with anyone or going out to lunch or going to do anything. So she had to be quarantined. But though she did get tested, which turned out to be negative, but since then, she's been more precautious about things. So when she gets home from work, she takes a shower right away because she wants to be on that safe level of, okay, washing hands. That means I can wash my whole body and clean myself off with the germs. I just completely switched jobs myself. I work in assisted living, where I work with a lot of elderly folks who are older, who have more health problems than other people. And I'm concerned for myself because there's nobody that come in, and I'm only working with the people who are in that facility who could have it at one point. And, you know, just being concerned for everything and know how it is, it's scary. And that's where I am more wanting to train the athletes on it, about how they can protect themselves with this pandemic. We have an athlete who's close to 50 years old, and she has more health problems than anything. I used to live with her, and she is afraid to get out of the house. And she doesn't know what to do. Nobody comes sees her, but she likes that social stuff. And so it's kind of hard to balance. If I go out, am I going to get sick? Do I risk my own life, or just should I stay? So it's the knowing of what needs to be done to protect themselves from the pandemic.
Kevin, do you have anything to add there?
If I understand the question right, I've seen it on one of the Facebook groups I'm part of. We had to cancel our fall sports, so I'm a special sport member for Cass County too. So I read the comments just to be a gentleman, be part of the board as an athlete, and it's emotional because one of the I forget the name of the athlete, but that's all right though. But one of the athletes asked if bowling was being canceled because bowling is a huge sport for Indiana Special Olympics. Because the neat thing about bowling is it's the best sport for worlds. But it's nice to be outside, but still bowling. Some of our athletes have bowling's good exercise for them. They're what physically capable to do, you know. And I've heard Indiana's the biggest state one time, like years ago, and if it still is, but bowling's big in Indiana. We have a big chapter in Cass County for bowling, and I hope things get better before the basketball season. But if it does, I think we should sanitize our sports equipment and be prepared for the ball game or any games.
So it sounds like some of the concerns you're hearing from your friends and community members is worry about isolation, just having so many social opportunities off the table right now, and also worries about staying safe. It sounds like quite a few people live with parents, and if you're going out to work and bringing that home, if your parent is your caregiver, that kind of puts you in a bit of a spot.
It does. But I live by myself, but all these athletes, they have group homes, and it's a crazy pandemic right now, and that's why the social aspect is change. Because I used to have a walking club at our local mall, which is not much left, and we're lucky to have a walking club, but this pandemic it's hurting us, our athletes and the staff members of the group homes. We're here to have a good time in Special Olympics, but we're going to stay strong about it.
Well, a lot of it, I think the athletes will really miss is that social interactions. And for example, there are athletes who, I know for a fact, are social going. And since they're home, they don't have that. So the only people they have is their parents or the group homes. And half of the times they're just quarantined from everything and they don't, being alone, being not able to talk to people, it is most of the things that the athletes like doing. And if they can't, they feel alone. They don't feel like they have people. So I guess that's what it comes down to is there's no sports. I mean, they eventually will bring stuff back, but it's hard for everybody.
Dr. Ciccarelli, I'm going to bounce over to you for a moment. I have one question specifically about what Nastya just brought up, and then I have a question right after it about the pandemic and some of its effects here. But what Nastya was just mentioning was isolation, and isolation in anybody can trigger mental health issues. What are some of the mental health disparities we see in the community of folks with disabilities, especially given that it doesn't seem like a lot of
there is more. There's a higher rate of mental health complications in the population of people with disabilities. Specific to COVID, we're seeing a lot of anxiety, and anxiety occurs at a higher rate in the population of people with disabilities. And so and being either socially isolated or fearful about what you're hearing in the news or being told at work, all help build into a more significant anxiety, which then is more, emotionally paralyzing. And so we certainly are seeing that now in the pandemic. One other piece that I would add that we've seen because of COVID, we're now entering our 6th month of not doing the usual things. So if you had usual physical therapy, occupational therapy, speech therapy, behavioral therapy, and you're not getting that for now this long a period of time, you're going to start to lose some of the gains you were getting out of those therapies. And so people are worried about their health because of delaying routine, preventive, or ongoing therapies that were happening. And so certain things haven't been stopped. People are getting chemotherapy for serious cancers. We've still been having treatments for people like that, but the regular physical therapy, the regular behavioral therapies that are very important in the disability community, a lot of them have been attempted to move on to telehealth, and we're using lots of telehealth. And telehealth has pluses and minuses for people with disabilities. Some people have trouble interacting and responding to someone talking to them through a computer screen, whereas some others who are afraid to leave their house have the benefit of being able to get the care of telehealth. So, there are facets to adapting telehealth to people with disabilities as well.
Thank you.
As much internet access, for example, we know that people with disabilities are less likely to have internet access. And so then how do you even get to your telehealth if you don't have internet? And so there's a number of those issues related to COVID that I think are highlighted in the population of people with disabilities.
Thank you. That covered the question I was going to ask specifically about the pandemic. I wanted to return to the mental health piece. From my understanding, it can be difficult, especially if you have an IDD, to get treated for a mental health issue. Is that correct? Am I understanding that correctly?
Well, access to mental health, when I have to pick where the biggest disparities are for people with disabilities, I think mental health and dental care are the two I pick. And mental health, many people have trouble finding counselors who can do talk therapy with someone who's very accommodated to communication. And many counselors just decline caring for people who have autism or intellectual disabilities because they aren't trained to do that. But then there are very few people who are specifically trained in the mental health of this population. And so it's a catch-22. So it's another big area where we need to do more training of health professionals who provide mental health services.
We've talked a bit about the IU program that is getting underway. What other resources exist for physicians hoping to improve their own capacity to treat people with disabilities of any kind?
There's a national association called the Association of Developmental Medicine and Dentistry, American Association of AADMD, and they're working on curricula for health professionals, for dentists and physicians in particular. There are a number of university centers for excellence in developmental disability around the country who have special projects in education around serving people with disabilities. And I particularly like, we actually got permission from the University of Kentucky's program to use a piece of their work in our work at the School of Medicine here in Indiana. And so both of those are kind of the broader ways people can learn more.
Thank you. I just looked at the time. Oh my gosh, we have 8 minutes. So I'm gonna blast through a couple of wind down questions, and these are for everyone. First up, what do you, Dr. Ciccarelli, Nastia, Kevin, what do you as an individual wish other people knew about people with disabilities and their healthcare? I know that's really broad, but any thoughts you have that you want to share?
It doesn't matter. A person with a disability is just as smart as anyone else. You know, we have hobbies just like the doctors or whatever, you know. That's the cool thing about being a human being is we have a different imagination just like anyone else. I used to clean doctors' offices, and I used to brown nose doctors of music trivia, and it was like, yeah, I know that guy. So it's pretty cool that people with disabilities see the world as a different place, just like the doctors do, or anybody.
The biggest thing that I would say, truthfully, for doctors to know, we are human beings just like everyone else. It really doesn't matter if we have intellectual disability. We want to be treated like everyone else. Like with Kevin, like he's saying, we have hobbies, we have all this stuff. We're just like everyone else. We don't want to be treated with specially. I don't know how to use that word if I'm saying it correctly, but we are human beings. We want to be treated equally. It's more of the doctors and people understand that we may take things slower processes, but we're like everyone else.
I think I would just second or third what everybody said. That I've been taught to think about the world, and I like this, so I'm going to share it, that we're all neurodiverse, and using the term that we all have neurodiversity. It's not one person is typical and one person is atypical, but there's this whole spectrum of what we all look like, and we're each uniquely different. And we each have our strengths and our weaknesses. And regarding people who have regarding people as persons, not the label of the disability, is what I think both Kevin and Anastasia are saying. We're people. All of us are people, regardless as so, and then help us the way we need help. And I think that's a great message that maybe Anastasia and Kevin said better than me, but I'm adding, I agree.
This question is kind of specifically for Nastia and Kevin, because Dr. Ciccarelli kind of answered it already. We were talking earlier about what people could do basically if they want to get better at this, get better at talking about people with disabilities in their healthcare, get better at helping, like as a doctor doing that. Nastia and Kevin, if people want to just get better at this, what do you think they should do?
Truthfully, to get better at doing their job or better of hearing, it's take the extra time to hear what the person is saying instead of rolling it off like we didn't say it. Just try to take the extra time to know, okay, so this is what this person is like. Maybe I need to rethink how I need to reward things. So it's the time, the extra time to understand the athlete and the extra time to do their job better at that. So they will have a better outcome of understanding people who have intellectual disability.
If I understand the question right, over the years, the local Special Olympics chapter has networked with Kiwanis and Kiwanis, and there's another nonprofit out there, something like Kiwanis, or other nonprofits for doing public speeches, or athletes doing public speeches of these, or Rotary, that's the name, Rotary and Kiwanis or other nonprofits have athletes or people with intellectual disabilities do speeches of networking those kind of peoples, because they're more than doctors in those clubs. They're business leaders and lawyers and self-advocates for small town America or any sizes. It's a good ideal.
Kevin, when we talked before this panel, you mentioned that something you thought people could do that would be really helpful for you and for them would just be if people came to volunteer at Special Olympics events. Could you talk more about your thoughts there?
Yes, and I thought of that a second ago. Well, one of my clubs, I'm friends with I get confused, Rotary and Kiwanis, but one of my friends, he's a lawyer, and he's called me. He's asked me some questions about, hey, is this Special Olympics event still coming up soon? You know, it's a good way to recruit volunteers. Even over the years at our local Special Olympics events, the special education teachers would come to the Special Olympics events, and they would have a smile on their face, you know. And I'm friends with some runners at the local YMCA. We would have some runners at a YMCA would do times and stuff, and they would feel just as special as the business leaders and the special education teachers or athletic trainers at a Special Olympics event.
Thank you. It's 2 minutes to 8, so I guess we should wind down. I cannot believe how quickly that hour went. Well, first of all, thank the three of you so much for being here tonight and for sharing your insights and your stories. Also, thank you to Luna Language Services for being here and helping us to make this discussion more accessible. Thanks to the folks over at WXXI, Move to Include, and the Corporation for Public Broadcasting for making this project possible for us. And last of all, thank you for everyone in the audience who joined us. We know that this is a huge topic that requires much more than 1 hour to unpack fully. If you're curious to learn more, our friends at All In, the statewide talk show over at Wfyi, they'll be talking about health disparities and disabilities on Monday and during their usual time of 1 p.m. to 2 p.m. So if you'd like to listen in and learn more, tune your radio to WFYI at 90.1 FM at 1, or you can stream it through the WFYI website or check it out later on All In's webpage a little later in the week. And also airing right after this panel tonight at 9 o'clock is a really wonderful documentary from 12 Star Media about the Indiana School for the Blind and Visually Impaired. The students at that school have been working with several Indiana arts organizations to help make their programming more accessible. I got to hang out with them a little bit while they were doing their project with the Idle Museum, and it is really cool to see these very smart young people at work. You can see that film called No Limits at 9 p.m. on Wfyi 1. While the focus month for Move to Include is officially over as of Saturday, we'll still be airing pieces that center the voices of people with disabilities. We have a series of audio diaries coming out in the coming months, so please stay tuned for that. We're really excited about them. To catch up on the stories we've told and the people we've talked to over the course of the project, check out our Move to Include website, which is wfyi.org/move-to-include. And last but not least, Side Effects is staying in touch with audience members over the election season through a regional text group called the Midwest Checkup. So periodically we send out a text inviting your questions on a given topic, and we'll do our best to answer those questions through reporting or through Facebook Lives like this one. If you want to join that group, text the word health to the number 73224. We would love to hear from you. That was a lot. I apologize for the info dump here at the end, but thank you all so much for joining in. And Mary and Nastia and Kevin, thank you guys so much for being here.
You're very welcome.
Pleasure to do it with all of you guys. Thanks.
Thank you so much for inviting us.
And with that, I will say good night. So good night, everybody.